Hello everyone, and welcome to the last lecture of the surgical sessions run by Mind the Bleep. I hope you've enjoyed all the other lectures. If you haven't been able to watch them, you can catch them all on YouTube. Just search for Mind the Bleep surgical series. So this lecture is on perioperative complications. As mentioned previously in our lectures, this course is designed by 4 junior doctors. We're currently F2s with an interest in surgery. We've created this surgical sessions course to prepare final year students in particular for their surgical rotations as FY1 doctors. So we're not focusing that much on pathophysiology and sort of deep surgical procedures, but rather on what you will see on the ward as surgical juniors. If you have any questions during the lecture, don't hesitate to comment on the Facebook chat or send us an email on webinars@mindthebleep.com if you have any questions you don't want to ask during the lecture. So as mentioned, the general format is to prepare you as FY1 and FY2 doctors for your surgical rotations. We focus on the clerking, we focus on identifying diseases and etiology and causes of different presentations you might see as a surgical junior, investigations that you're expected to order and identify, and then the initial management as a junior doctor. And then we'll try and ask you some questions along the way as well to make it a bit interactive. This is me, my name is Freya. I'm one of the FY2 doctors with an interest in surgery. So for this lecture, the key learning points is optimising the surgical patient, recognising risk factors for operative complications, identifying common post-operative complications, and understanding the management of common post-operative complications. So going through this lecture, just think that you're the FY1 on take, clerking a patient or on call, being called by one of the nursing staff to see a patient that they're concerned about. So as mentioned, we're going to try and have some interactive questions along the way. So if you log into polev.com/mindthebleep519, you should be able to get the questions up. This link will also come up during the questions, so if you miss it on this slide, don't worry. So we'll start out with our first question. What is the most common cause, the question is supposed to say, of post-operative mortality globally? Is it sepsis, ischemic stroke, pulmonary embolism, major bleeding, or ischemic heart disease? So I'm going to carry on and come back to the answer in a bit. So post-operative complications are fairly common. About 20,000 to 25,000 deaths occur yearly in the UK following surgery. 80% of the deaths are seen in high-risk patients. And we'll talk a bit about what makes a patient high risk in the next couple of slides. And 10% of surgical inpatients are classed as high risk. Post-operative complications can be classed as either immediate, so less than 24 hours after surgery. They can be early, which is within 3 days post-surgery, intermediate, which is anything from 4 days to 2 weeks after surgery, and late complications, which is any complications after 2 weeks post-op. So typical immediate post-operative complications, anything sort of in the hours after surgery, are often associated with anaesthetic. So that can be anaphylaxis or allergy from the anaesthetic agents or the pain relief given post-op. Primary hemorrhage, so this is bleeding that has occurred during operation, so continuing to bleed in the first hours after surgery. Fever, we'll talk a bit about post-operative fever in later slides. And renal failure, and this is often due to pre-renal failure, so hypovolemia can be caused by either dehydration due to the surgery or from bleeding. So early post-operative complications, anything between 1 to 3 days post-op. atelectasis, so collapse of either part of the lung or entire lobes, can be caused due to pain post-op. So patients often tend to not take deep breaths post-op because of pain, especially after intra-abdominal surgery. And this can cause collapse, which can also lead to pneumonia. Secondary hemorrhage. So this is bleeding post-operatively, which can often be caused by an increase in blood pressure after surgery, causing leakage of vessels that weren't previously bleeding. MI, so any ischemic heart disease, is very common after surgery. Nausea, vomiting, and post-operative alias are all common post-operative complications. We'll talk a bit about all these later. And sepsis. So fever after surgery is very common, something you're often called to as a surgical junior. And this can be any hospital-related fever and surgically related fevers. So chest infections are very common, as mentioned, often because of the pain from intra-abdominal surgery, meaning the patient doesn't take deep breaths, causing lung collapse, and therefore infections. Any urinary infections, patients will often have catheters, either intrasurgically or after surgery because of possibly urinary retention. Wound infections, so this can be both from the ports, the small little wounds, or from larger laparotomy scars. Any cannulation, so any needles or plastic going into the body, can all be infected. So any complications occurring between 4 and 14 days differ slightly from earlier causes of post-operative morbidity. Around 4 days, you start running the risk of an anastomotic leak in colonic surgery. You also see collections starting to occur at around 4 days. So before sort of 5 to 7 days, intra-abdominal collections or any sort of surgical collection formation is very unusual. Wound infections as well. So infections and collections take some time. They take a few days to start building up and start manifesting. And the same with pneumonia and UTI. So you can see infections of the chest and UTIs prior to 4 days, but these are also more common after a little bit of time in hospital post-surgery. VTE, so patients at around 4 days have often been lying very still due to the pain, fatigue, and just post-operative immobility, and this increases the risk of venous thromboembolism. So after 14 days, there is less risk of things like infection, but patients may still be quite immobile and therefore run quite a high risk of VTE. Incisional hernias, quite common after intra-abdominal surgeries. Adhesive obstructions, so this can occur quite a while after surgery and often causes small bowel obstruction. And in orthopedic surgery, you might see delayed or non-union of fractures. Right, so what is the most common cause of post-operative mortality globally? And the answer, which is actually quite a few of you have answered, is ischemic heart disease. So according to the Lancet, the most common cause of post-operative morbidity, so that will be within 30 days of the surgery, is ischemic heart disease, accounted for as many as 17.3% of surgical patients. Stroke accounts for 10%, and COPD 5.4%, so they're the most common causes. Right. So what constitutes a high-risk patient? So we have patient factors and then we have pre-existing morbidity. So patient factors includes factors such as increasing age. So any patient who is at an increased age will have many comorbidities. They will be frailer. They will have less of respiratory reserve, and therefore run a higher risk of post-operative complications. Smoking increases your risk drastically. Your baseline activity level, so inability to perform activities of daily living. We'll talk a bit about sort of the baseline assessment of a patient's ADLs later. And then obesity is a very strong risk factor for post-operative morbidity. Pre-existing morbidity includes any pre-existing infections. So a lot of patients who are requiring surgery already have an ongoing infection. They're requiring emergency surgery. Any pre-existing anemia, so to try and optimize a patient's hemoglobin before going to surgery. Pre-existing heart disease and ischemic heart disease is quite a strong risk factor for post-operative morbidity. COPD and any respiratory disease in general. Diabetes, poor glycemic control, both before and during the operation, increases the risk of morbidity and mortality. Any immunosuppression and malignancy, especially malignancy with ongoing chemotherapy or previous radiotherapy, that renders in particularly the bowel susceptible to risks following surgery. So I'm sure a lot of you have seen the Asa Scoring System. So this is done for every surgery, and it classes the patient in a group, in a category from 1 to 6, based on their general state of health. So ASA Class A is a normal healthy patient. Class 2 is a patient with mild systemic disease. Class 3 is the patient with severe systemic disease, and you'll often see the surgical patients being either Class 2 or 3. Class 4 is a patient with severe systemic disease that is a constant threat to life. Any operative patient that is a Class 4 will often need urgent surgical management rather than elective surgical management. 5 is a patient that is requiring urgent surgery and is not expected to survive without the operation. And 6 is a patient who is already dead and is requiring surgery for the removal of organ for transplants. You might also see from the operation notes that surgery is often classed according to their severity. So we have 4 different categories here. Grade 1 is classically operations or procedures such as endoscopy, breast biopsies, or laparoscopic surgeries. Grade 2 includes quite common procedures, elective operations such as hernias, varicose veins, adenotonsillectomies, knee arthroscopies. Grade 3 includes things like hysterectomies, TURPs, and thyroidectomies. They're a bit more invasive surgery. And grade 4 are the surgeries that run the highest risk of morbidity and mortality, such as a total hip replacement or a TAVI for a AAA or a colonic resection. So, as an F1, you will be expected to see quite a lot of post-operative patients. And some of the most common things you'll be called for are things like post-operative fever, patients with post-operative respiratory distress, hypotension, nausea and vomiting, any sort of wound complications, whether it's bleeding, redness or discharge, and a patient who is not opening their bowels post-operatively. So we're going to go through some of these causes that you commonly will be called for as a surgical junior. So first we have our next question. So as a rule of thumb, 1 unit of red blood cells increases hemoglobin by how much in grams per litre? And I'm sorry, we can't quite see the numbers. Let me just close that. So the options are either 5, 10, 15, or 20. And let me just activate this question. And you should be able to answer it now. So we'll carry on and come back to the answer in a little bit. Right, let's move on to our first case. So you are called to review a 21-year-old female with hypotension. She's about 5 hours post-laparoscopic cholecystectomy. So you start off with your examination. when you're called to see a patient on the ward, and especially if you're not quite sure what to do, always go through your ABCDs. It's quite a clear, concise, efficient way of examining a patient, and it also identifies severe causes of disease and especially post-operative complications. So you start with your her airway is a patient, she's chatting to you, going on to your breathing. So her respirate rate's a bit high at 23. Her saturations are 97% on room air. On auscultation, her chest is clear bilaterally. You can't hear any crackles. You can't hear a wheeze. Circulation, the heart rate's a bit high at 110. You feel her peripheries and they're cool bilaterally. Her blood pressure is fairly low at 90/50, and she has a thready, regular radial pulse. She has a good urine output of 30 millilitres per hour post-op with a catheter in situ, and her heart sounds normal. The capillary refill time peripherally, however, is 4 seconds. D, she's GCS 15, her pupils are equal and reactive bilaterally, and her BMs are normal. And you do a quick abdominal examination, and she has widespread abdominal pain, but no bruising as far as you can see, and her wound sites appear clean with no bleeding. So your initial management is this patient. This is a post-operative patient, only 5 hours after surgery, and she's already hypotensive. So some alarm bells should start ringing here, and you should start managing the patient as a surgical emergency. So the initial thing to do is insert 2 large bore cannulae. Whilst you're doing this, you want to obtain a VBG and formal bloods. So a VBG is a very quick and easy way to get some important parameters, for example, hemoglobin in a surgical patient and a lactate. So in this case, her hemoglobin is only 92. Her preoperative hemoglobin was 125, and this is worrying. Her lactate is 4.1, and this is also worrying as it's very high. You want to send off your routine bloods, so full blood count, use needs, LFTs. Always send it off a cross-match if you're worried about bleeding in any patient or it's an operative patient in general. Send off a coagulation screen in a young patient post-operatively with tachycardia, hypotension, and a bit of a high respirate rate. You also want to think about cardiac causes and VT, so send off a D-dimer and a troponin in addition. At this time, you should think about contacting your senior, and you should potentially already have bleeped your senior in order to alert them of the fact that we have a post-op patient who is at risk of complications, for example, bleeding. Whilst you're waiting for your senior to come, you can assess the op notes. So anytime you're assessing a post-operative complications, post-operative patient, make sure you're familiar with the operation they underwent. So check whether there are any complications during the surgery, for example, anaesthetic complications, or any bleeding or any other complications of the operation. So in this case, it was an uneventful operation with no unusual intraoperative bleeding. You also want to perform common bedside investigations, and in this case, an ECG will be the most useful. And you want to have a look for any sort of heart ischemia from hypovolemia. And in this case, all it shows is sinus tachycardia. So hopefully you've already contacted your senior. The questions you want to ask is confirm how they want you to initially resuscitate the patient. And usually this will be in hypotension, a bolus of 500 millilitres of normal saline. There's no adverse effects of this in a young woman, and if there's any bleeding, this patient will need resuscitation before going to surgery. So give them a bolus, contact your senior, and request for them to guide you as to any further imaging required. So if you are worried about any post-operative bleeding, especially in abdominal surgery, the most important investigation will be a CT abdomen. This will be an urgent CT, and you're required to call the radiologist and request this urgently. It's important when you have an emergency like this that you follow up on your radiology. So call the the radiologist requests an urgent CT and then call the radiographer immediately and say that this has been vetted by the radiologist and you require this patient to go down for imaging urgently. In a young patient post-operatively, or any patient really post-operatively with tachycardia and hypotension, it's important to not become too focused on post-operative bleeding. So remember other causes, for example, VTE. So a pulmonary embolus is common post-operatively, and it's important to think about this as one of your differentials. And if the CT abdomen is negative and there's no post-operative bleeding, try to consider other causes and potentially request a CTPA. It's also important at this point, when you speak to your senior, whether to discuss the case with ITU. If this patient is having some sort of reaction to anaesthetic, or they're having bleeding that is going to require reoperation, it might be worth speaking to ITU and alerting them of the patient, and you might want to request bed space for the patient post-operatively. So post-operative hemorrhage can be either primary, so this is any bleeding that's caused during the actual surgery. It can be reactionary, so this is often when the blood pressure post-operatively rises comparatively to the blood pressure during surgery. So during surgery, blood pressure is often kept quite low to prevent bleeding. When it then goes up to its usual levels, post-operatively you might get new bleeding and previously non-bleeding vessels. Then we have secondary post-operative hemorrhage. So this is usually due to either collections or infections that cause damage to nearby structures that cause bleeding, and this is often several days after surgery. Post-operative hemorrhage is a very high risk complication and requires urgent resuscitation, identification, and senior alertness. So make sure any patient post-operatively with hypertension, you do urgently escalate this to your senior. Most intra-abdominal post-operative bleeding will require a CT abdomen urgently, and often if bleeding is identified, the patient will require reoperation. So back to the question. As a rule of thumb, 1 unit of red blood cells increases hemoglobin by how much in grams per litre? And correctly, it is 10. So if you have a hemoglobin of 90 in a bleeding patient, you want to request quite a few units of red blood cells, because 1 unit will only increase the hemoglobin by 10. Okay, moving on to our next question. Approximately how many patients experience paralytic ileus post-intra-abdominal surgery? So your options are 1%, 10%, 15%, 30%, or 50%. We will move on and look at the answers in a bit. So our second case, you're called to see a 54-year-old man post-laparoscopic inguinal hernia repair. He's 2 days post-op, his abdomen is distended, a nurse reports 1 litre of vomiting. He's not passing any flatus or opening his bowels since the surgery. So again, you want to go through your ABCDEs. He's talking to you and his airways are clearly patent. His rest rate's 18, so it's normal. His SATs are 97% on room air. His lungs are equal bilaterally with no added sounds such as crackles or wheeze. His heart rate's 92, so he's not tachycardic, but it's sort of a little bit higher than normal, and his blood pressure is 110/82. He's warm and well perfused, and his strong radial pulses. His heart sounds normal and is clinically euvolemic. Disability-wise, his GCS is 15, his pupils are equal, and he's afebrile with normal BMs. Should do a quick abdominal examination. You can see that his abdomen is distended and on percussion it's tympanic. However, he's not peritonitic, and there's some mild, widespread tenderness, but no local tenderness, no lumps felt. The wound site post-operatively is clean and you can't see any discharge or redness or bleeding. So your initial assessment, your bedside investigations includes an ECG. In this case, it showed nil abnormalities. As this patient is post-operative, you can do a quick VBG as well to assess in particular lactate, which in this case is normal. His hemoglobin is also normal, 125. You want to send off some formal bloods, and all his bloods are completely normal. And it's useful here to get a creatinine and a potassium post-operatively as well to assess for any renal damage or any hyperkalemia from the anaesthetic agent, which is quite common. A urea is also a good marker of intra-abdominal bleeding or GI bleeding because blood is metabolized in the GI system and causes a high urea. So because he hasn't opened his bowels yet and he's in mild pain with abdominal distension, you want to do an abdominal X-ray. And this is the X-ray you obtain, and you can see dilated loops of bowel. However, what you don't see is air fluid levels, and this is seen in mechanical obstruction. So this is obviously obstruction, but it's functional and it's post-operative. So this is what we call post-operative or paralytic alias. So this is a very common post-operative complication. Let's see if we've managed to get some answers here. Which affects as many as a third of operative patients. We're having a slight technical difficulty with the questions, but the correct answer anyway is 30%. So a bit of a disparity in answers here, but majority of you answered 30%, so that's great. So post-operative alias is essentially transiently impaired propulsion of intestinal contents. And it is one of the most common causes of delayed discharge from hospital. We're not quite sure why this happens, but it's thought to be a combination of causes, including sympathetic hyperactivity from the abdominal surgery itself, and inflammatory mediators from the abdominal contents being disturbed and the colon in particular being mobilized during surgery. Opioid use as pain relief is a strong risk factor. We know opioid use causes constipation and it can also cause paralytic ileus. And then electrolyte disturbances, especially hypokalemia, can cause ileus as well post-operatively. So next question. Which of the following is not a potential cause of post-operative alias? So we mentioned a few of the risk factors. So is it hypokalemia, opioids, dehydration, or post-operative mobilization? So the question is, which of the following is not a potential cause of post-operative alias? We'll come back to the answer in a little bit. So the clinical features of post-operative alias is a distended tympanic abdomen. You will hear that on auscultation. You'll also see dilated loops of bowels with air. Patients might experience abdominal pain, so they've not passed stools or flatus post-operatively, and they might be in quite a lot of discomfort. They might experience nausea and vomiting, and on auscultation of the abdomen, you might hear an absence of bowel sounds. So this is very common, and it's often not a dangerous complication of surgery, but it can cause quite a lot of discomfort, and as mentioned, it can cause delayed discharge. So the initial management is keeping the patient nil by mouth, especially if they're experiencing nausea and vomiting. You want to do a full assessment of the patient to identify any underlying causes. So for example, their electrolytes, check they're not hypokalemic. And if they are, you want to make sure you replace their potassium. If they're on opioid analgesics, you might want to try and reduce their opioids or even stop them completely, as these these increase the risk of ileus. Other drugs such as anticholinergics, oxybutynin, buscopan, those sort of drugs can cause ileus. They can also cause urinary retention, and they're quite important to not just use them willy-nilly post-operatively. And if you have a patient experiencing ileus, try and rationalize these medications and see if you can hold them temporarily whilst they're experiencing their obstruction. Then make sure the patient isn't dehydrated, so perform a full assessment of their hydration status, including their OBS and especially their postural blood pressure, which is a very good marker of dehydration, and rehydrate them if you think they are dehydrated. If the patient is vomiting and experiencing ongoing nausea, they might benefit from NG drainage until their nausea and vomiting has settled, until they've opened their bowels again. You want to make sure they're rehydrated appropriately and encourage mobilization. So mobilization is a really effective way of getting people to open their bowels post-operatively, and post-operative ileus, as said, is most commonly uncomplicated and will resolve spontaneously within 3 days in most cases. If it doesn't resolve within sort of 3 to 5 days, you want to consider any imaging to assess other causes of obstruction. So the question was, which of the following is not a potential cause for post-op ileus? And the correct answer is post-op mobilization. So quite the contrary, post-op mobilization, especially early mobilization, is important and can often resolve ileus. Right, so the next question . Not next question, next case. Case number 3. You are called to see a 72-year-old man 4 days post a hemicolectomy for perforation secondary to diverticulitis. He spiked a temperature of 38.3. He complains of ongoing post-op abdominal pain and a mild cough. So your main complaint here from your patient is a cough, abdominal pain and a fever. So again, you want to go through your A to E's, make sure the airways are patent. On breathing, his rest rate is sort of on the brink of being high. His SATs are slightly low on room air at 93%. On auscultation, you can hear a right middle zone crepitation. Otherwise, he's a bit tachycardic, his blood pressure is stable, and he's warm and well perfused with strong radial pulses. His heart sounds are normal, and his urine output is 20 milliliters per hour, which is satisfactory. He's clinically euvolemic. He's GCS 15, pupils equal, he's got a fever as mentioned at 38.3, and his BMs are normal. On abdominal examination, his abdomen is soft, but he has widespread tenderness. His wound sites are clean and his calves are soft and non-tender. So the first thing you want to do is your bedside investigation. So make sure you obtain an ECG in a patient with tachycardia. An easy assessment to do in a patient with fever is a urine dip. Not only can you assess for signs of infection or leukocytes and nitrites in the urine, but you can assess other things like blood and protein in urine as well, which is important in other causes of infection, such as renal stones causing sepsis. Because this patient is desaturating on room air, you might want to consider an ABG to assess his oxygen status. As part of your septic screen, you want to obtain your wound swab And if the patient is experiencing diarrhea, you want to do a stool microscopy and culture as well, and include a C. diff in this investigation. So with any patient who's spiking a temperature, especially a post-operative patient who's undergone surgery and has cannulas and several sort of sources of infection that are possible, you want to do a full septic screen. So we mentioned some of the bedside investigations you can do, and make sure you send off a group and save in a coag, because this is a surgical patient. You want to do cultures, including blood, sputum, urine, stool, wound, and in this day and age, you want to do a COVID test as well. When you do your investigations, you want to think of all the sources of infection. So in our case, our patient had coarse crackles in the right middle zone. So you obviously want to do a chest X-ray. But in any septic patient post-operatively, even if you can't hear any crackles, it might be worth doing a chest X-ray anyway, as post-operative chest infections are very common. As this patient is post-operative, you want to alert your senior to the fact that he's spiking temperatures, and you want to ask whether there's a need for further investigations, such as a CT abdomen for a possible anastomotic leak, which can cause a raised temperature, or whether you want to do a Doppler or a CTPA for a DVT. So it's important to remember that a cause of post-operative fever is also VTE, and this can be the only sign of a PE post-operatively, so keep it as part of your differentials in any fever, any patient spiking a temperature. So you do your chest X-ray, and this is your result. So as you can see, you have quite a nice middle lobe consolidation on the chest X-ray. So your initial management of a patient presenting with a hospital-acquired pneumonia will be immediate resuscitation, including oxygen. This patient is slightly hypotensive and tachycardic, which might alert you to the fact that he is becoming septic. So you want to resuscitate him with a fluid bolus, prescribe some antipyrexials, for example, paracetamol, and quite quickly prescribe empirical antibiotics. And they will be empirical because you don't have any culture results. So in this case, you want to follow local policies, and it will usually be a broad spectrum beta-lactam, such as coamoxiclav. In patients, any inpatient, but especially surgical patients who have a higher risk of morbidity and mortality, make sure you always discuss the ceiling of care or assess ceiling of care with your seniors. So is this patient ward-based, or will they be for further interventions such as non-invasive ventilation, or even ITU admission for inotrope support or intubation and ventilation? In any patient with sepsis, it's also really important to monitor urine output and a strict fluid balance. So post-operative pyrexia will be quite a common thing you're called for. Immediate post-operative pyrexia, so this is any fever within 24 hours of surgery, is very common. It's usually low-grade post-operative fever, and it occurs in about 1/3 of operative patients. And this is sort of just a result of inflammation post-surgery. It might be due to the medication or the blood products. So assess what medications they've had, assess the prophylactic antibiotics they've had, assess whether they've had any blood transfusions, and if they're having ongoing blood transfusions, it's important to recognise that this may be a transfusion reaction. But in most patients within 24 hours after surgery, they will have a completely non-complicated low-grade temperature just because of the fact that they've had surgery. And in this case, you can prescribe some paracetamol and monitor them and make sure they're hemodynamically stable. You always want to do your septic screen, but you don't necessarily need to spend hours finding a source of infection. As mentioned, VTE is a cause of post-operative pyrexia. It can just cause a fever and no other signs. So this is important to keep as part of your differentials. And the same goes for ischemic heart disease. So myocardial infarction can just cause a temperature as an inflammatory response. So acute postoperative pyrexia is any fever occurring within 7 days of surgery. This is usually due to infections, so whether that's of the surgical site, a UTI. This can often occur because patients either have catheters in situ postoperatively, or because they're experiencing urinary retention due to medication or opioid use, for example. Pneumonia, as mentioned, because patients don't take deep breaths due to pain. C. diff, so any patient who is in hospital is unfortunately at risk of getting C. diff. So any patient with diarrhea in hospital should be immediately moved to a side room and isolated and assessed for C. diff. We mentioned VTE and MI, and then blood transfusion reactions or medication reactions. And remember, pancreatitis is part of your differential as well. A lot of the medications we give, including steroids, can cause pancreatitis, so keep that as part of your differential as well. So any fever between 1 and 4 weeks after surgery, you start thinking again about infections, but more commonly this will be deep abscesses forming or infections of prostheses in, for example, orthopedic surgery. Patients might still get UTIs, pneumonia and VTEs, but ischemic heart disease will be less likely in this time frame after surgery. As a rule of thumb, in days 1 to 2, you want to consider a respiratory source. So it's quite unlikely to get abscess formation or infection of a wound this close to surgery. So consider sort of respiratory sources of infection. In day 3 to 5, you might consider a urinary tract source, and day 5 to 7, consider infections of the surgical sites or deeper abscess or collection of formations. This is quite a gross rule of thumb, but it makes it a bit easier to identify possible causes. The 5 W's of post-operative infections, post-operative fevers, are also quite useful. So the first one will be wind, and this is respiratory sources of infection. So this is 1 to 2 days after surgery. Water will be 3 to 5 days, so this will classically be UTIs. Walk, so this will be VTE. This will be 4 to 6 days after surgery. Wound, 5 to 7 days, so this includes abscesses and collections. And then wonder about drugs, which is any time post-operatively, so that will be anesthesia or antibiotics. Remember to identify patients who you think might have sepsis, so know your SIRS criteria. The Q-SOFA criteria are quite easy to remember, so any systolic blood pressure below 100, or respiratory rate over 20, or GCS less than 15. And remember to identify this and act according to the sepsis 6 within the first hour of identifying sepsis. When you want to escalate your patient with postoperative pyrexia, it depends on their clinical state. Assess them for septic shock, so this is any patient who is still experiencing hypotension despite fluid resuscitation. If they have a lactate of over 4 or no response to the antibiotics or fluids or oxygen you've given them, you want to immediately escalate to ITU or to your senior. And remember to, in the days following the cultures, remember to routinely assess the cultures and discuss them with microbiology for the treatment that matches the cultures and sensitivities. And it might be useful in a patient, for example, with the UTI, it's useful to go back in the cultures and have a look at previous cultures as well to see whether there's any typical bug that recurs. Right, so we sort of missed this question a little bit. I'm not sure if you can see it, so I'll just close the presenter view. But the question is, what percentage of patients undergoing surgery die during the same hospital admission in the UK? So it's a bit of a morbid question, but it's just to alert you to the fact that the death rate during surgery is what I would say is fairly high. The correct answer here is 1.6, which is what most people have answered. And this is obviously, this number is a lot higher in low-income countries, but 1.6 is still unacceptably high. Okay, then we have the final question. Which antiemetic should be used with caution in young adults? Is it IV metoclopramide, PO cyclazine, IV ondansetron, or IV domperidone? So we'll come back to the answer shortly. Okay, case 4. You're called to see a 23-year-old lady 8 hours post-laparoscopic appendectomy complaining of severe nausea. On examination, her news is 0. She's afebrile and hemodynamically stable. Her abdomen is soft and she has mild localized tenderness over the wound site, but the wound sites are clean and she is clinically euvolemic. She is passing flatus postoperatively. So you want to do a couple of bedside assessments, so assess her urine output and assess her gastric motility. So you've already asked her about her bowels and she is passing flatus, and make sure you record her fluid balance, record an ECG, and assess her most recent bloods for any rising inflammatory markers or any electrolyte disturbances. Make sure she doesn't have an AKI postoperatively, so check her creatinine and her urea. You might want to do some new bloods, but her main complaint here is postoperative nausea. So this is quite a common complaint and something you are frequently called about when you're a surgical F1. Patients very, very often experience nausea postoperatively, and there's a certain risk, a group of patients are at higher risk of postoperative nausea, and we'll touch on that in the later slide. But the initial management will be to assess the operative notes, assess all her bloods, her recent imaging, and make sure there's no underlying cause of her nausea and vomiting. So any patient on opioids, despite them being good pain relief, they do cause nausea. So it might be worth rationalizing these and reducing them or even stopping them if you can. If the nausea is caused by pain, make sure you do optimize her pain control. You might want to add in an NSAID rather than an opioid if it's a combination of pain and opioid-induced nausea. Ensure that she's adequately hydrated. Dehydration postoperatively can also cause nausea. If she's vomiting profusely or she can't keep anything down, including fluids, you might consider NG tube decompression for the time being until her nausea is controlled. Then you want to start prescribing an antiemetic. So this is when you've excluded any other causes of post-operative nausea. So post-op nausea and vomiting affects about a quarter of patients within the first 24 to 48 hours post-operatively. And the patients that are at high risk of post-op nausea are generally females, generally young females, so anyone under the age of 50. Anyone with previous post-operative nausea, so this is part of your pre-operative assessment, is asking about previous anaesthesia and whether they've experienced nausea from this before. Patients who are smokers will also be at higher risk, and the cause of this is unclear. Then we have operative risk factors. So anyone going through intra-abdominal laparoscopic surgery or laparotomy surgery will be at higher risk of post-op nausea. Gynae surgery in particular, this is slightly also unclear, but it might be an autonomic response from the sort of irritation of the viscera during gynae and intra-abdominal surgery. Any middle or inner ear surgery, which obviously damages or causes a disturbance to the vestibular system, which can cause almost a motion sickness. Poor pain control as mentioned, opiate analgesia and spinal analgesia, and then inhaled pain relief such as nitrous oxide or isoflurane can also cause post-op nausea. So as mentioned, make sure you assess for any underlying causes before you just treat it as generalized post-op nausea. So ensure they've opened their bowels and they're not obstructed. Ensure they've not got an underlying infection, which often causes patients to become nauseous. Ensure their electrolytes are within normal ranges and check their BMs for DKA. Stop any opioids if you can, or reduce the opioid dosing if they're not in too much pain. And just be conscious of the fact that antibiotics can also cause side effects. And if they're not necessary, just rationalize them if they're causing nausea. Patients with raised intracranial pressure will also experience nausea. This is quite an uncommon cause of post-op nausea and vomiting. And then just general anxiety can cause patients to feel sick. So we won't go through all the pathophysiology of nausea, but it's quite useful to just be aware of the different causes and the different neurotransmitters the antiemetics work on, because this makes for a more effective management strategy. So with the different antiemetics, you have the main categories, which are the dopamine antagonists. So this includes metoclopramide and domperidone. These are prokinetic agents and are often avoided in abdominal or GI surgery. This is because any prokinetic agents in a bowel obstruction will be quite detrimental. So try to avoid metoclopramide in particular as much as you can in the post-operative patient, especially in general surgery. Then we have the serotonin antagonist, so ondansetron. This is quite useful and quite commonly prescribed antiemetic. Just be cautious of the fact that this can cause constipation. So in a patient who is experiencing nausea because of constipation, ondansetron might not be the best option. And then we have H1 histamine receptor antagonists, which includes cyclazine. Cyclazine is important to avoid IV because it can cause a high and it can cause an addiction. So always give it orally when you can. The other thing to be cautious of with cyclazine is it does have anticholinergic properties. So just administer it with caution in the elderly because it can cause urinary obstruction and retention as well. Ondansetron, make sure you obtain an ECG before prescribing it, as it can cause a long QTC. Metoclopramide is important to avoid in young women, particularly because these patients are at risk of extrapyramidal side effects from metoclopramide. The other group of patients who you should avoid it in is anyone with Parkinson's disease or Parkinson's symptoms because of the anti-dopaminergic effects. So the question, which antiemetic should be used with caution in young adults? The answer is metoclopramide because of the risk of extrapyramidal side effects. Okay, so final case, we'll whiz through this. You're called to see a 65-year-old lady 4 days post a nephrectomy for a renal cell carcinoma. She complains of shortness of breath only. So you go through your A to E again. You notice she has a high rest rate and her oxygen saturations are 92% only on room air. Her chest sounds are, however, clear. She's tachycardic with a stable blood pressure and she's warm and well perfused with a regular heart rate. Her heart sounds are normal. She's afebrile and GCS 15 with normal BMs and pupils. Her abdomen is soft and non-tender and her wound sites are clean and her calves are also soft and non-tender. So you do your initial bedside investigations and this includes an ECG. So on your ECG, you can see she's clearly tachycardic. The other thing you can see is that she has some T-wave inversion, particularly here in leads V1 and V2. So these are the right precordial leads. In addition to this, you might see a right bundle branch block, which indicates, all these together indicate a right heart strain. So in any patient post-operatively with tachycardia and low saturations, just be wary of any sort of VTEs, in particular PE. So for your initial investigations, send off your routine bloods and remember to include a D dimer and a troponin in these. As the patient's desaturating with a high breath rate, you might want to do an ABG to assess their oxygen levels and their acid-base balance. So your initial investigation will always be a chest X-ray, but make sure to contact your senior early and ask whether they would like any further imaging for example, a PE. So this will be a CTPA. And before you do a CTPA, it's important to assess the patient's renal status. So make sure they don't have a chronic kidney disease or an AKI. That means that they are at risk of renal failure from contrast from CTPA. So just always have VTE in the back of your mind in a post-operative patient. The management in post-op patients will be something to discuss with your seniors, because patients are obviously at high risk of bleeding post-operatively, but they're probably at higher risk of morbidity and mortality from APE. So the usual management will be low molecular weight heparin or unfractionated heparin in patients with renal failure. And the duration of oral anticoagulation will depend on your local guidelines, but usually it is 4 to 6 weeks in patients with temporary risk factors, and 3 to 6 months for patients with no clear cause or lifelong for some patients as well. So just make sure you adhere to your local guidelines when prescribing long-term anticoagulation. But post-operatively, you often have quite a clear cause and they will unlikely be on long-term anticoagulation. Okay, so whizzing through the last couple of slides there, but I hope that wasn't too fast-paced for you. So just in summary, patients who are operative patients must be thoroughly assessed to assess their surgical risk and try to identify patients that are in the high risk category. Ischemic heart disease, sepsis and post-op bleeding are all common causes of post-operative mortality. So make sure you keep them in the back of your mind when you examine your patients post-op. And remember to always escalate the post-op patient early. So you might want to alert your, a lot of consultants will want to know of any of their surgical patients that are experiencing any post-op complications early on in the course post-operatively. Okay, so this was the last episode of our surgical sessions. I hope you've all enjoyed them. Please go on to the Mind the Bleep website for any further sessions on other medical specialties as well as surgical specialties. As mentioned, you can find all our lectures on YouTube, and we'd really like your feedback as always. So if you wouldn't mind using the QR code and just leaving us a little bit of feedback. If you want to ask a question, please email us on webinars@mindthebleep.com. Thank you all for watching. Hope you have a lovely Christmas, and please follow the Mind the Bleep webpage for any other resources.